Hello, everyone. Welcome to today's webinar. I'm Kelly McSweeney, contributing editor at Chemical and Engineering News, and I will be moderating today's event. This webinar is titled Translational Pharmacology of CNS and Metabolic Disorders for Testing New Modality Therapies, and is being sponsored by WuXi AppTec. CNEN works with sponsors to identify topics of interest and value to CNEN's audience, and consistent with CNEN's mission to provide news and analysis of the chemistry enterprise in a timely, accurate, and balanced fashion. During the webinar, you can adjust the size of the slides on your screen by grabbing the lower right corner with your mouse. If you need technical assistance, please look at the Help widget at the bottom of the screen or type your query into the Q&A box. If you are disconnected during the webcast, please log in again according to the instructions you received earlier. You are encouraged to contribute to the success of this webinar by asking questions at any time during the presentation through the Q&A box on your screen. The questions will be answered at the end of the presentation, and as your moderator, I will be posing as many as time permits. Please note that CNEN does not endorse any company, products, or services that may be mentioned in the webinars, and that each webinar will be archived at CNEN online after the live webcast. The presentation today is being sponsored by WuXi AppTec. WuXi AppTec is a global company that provides a broad portfolio of R&D and manufacturing services that enable companies in the pharmaceutical, biotech, and medical device industries to advance discoveries and deliver groundbreaking treatments to patients. During the presentation, we will hear from Dr. Deming Xu. Dr. Deming Xu is a chief pharmacologist, executive director, and head of in vivo pharmacology at WuXi AppTec Discovery Biology. Dr. Xu earned a Bachelor of Science degree from Fudan University and a PhD from the University of Toronto. His research career of more than 25 years spans from academia to biotech and from pharmaceutics to CRO. His current research interests cover infectious diseases, NASH, fibrosis diseases, neurodegenerative diseases, and the microbiome, and disease mechanisms and target discovery. He has authored more than 60 research papers published in top-tier scientific journals. With more than 10 years of experience at WuXi AppTec, he leads the in vivo pharmacology services of both small and large animals. And with that, I will now hand things over to Dr. Xu.
Thank you very much for the introduction. My name is Deming. I'm the head of the in vivo pharmacology in WuXi Biology. It is my pleasure to have this opportunity to present this webinar. I will start the presentation by introducing the clinical relevance of NASH animal model and its importance, followed by a review of clinical trial results in connection with the animal model. I will discuss 3 types of animal models and their validities, and give 2 examples of the so-called homologous models. Then I will continue the discussion on our effort to understanding the NASH model and its great clinical relevance, and share some new insights. After that, I switch gear to talk about neurodegenerative diseases and their models in rodent and non-human primates, followed by metabolic disorders induced in non-human primates and their use in testing new modality. After a brief summary, I will discuss what we have found, how PCSK9 responds to metabolic induction in non-human primates and the possible implications. And then I'll wrap up with a quick discussion. So this slide summarizes the results of preclinical efficacy study of 3 NASH compounds in 2 different animal models. They are diametrically inconsistent with the outcome of clinical trials. Serendipity demonstrated efficacy in one of the animal model, MCD model, but fails to meet the trial benefit endpoints. Resmetirom and obeticholic acid are not efficacious in either model, but met their respective endpoints in clinical trial. The contentious question is that are these animal models clinically relevant? So the flip side of the coin, of course, is that whether we have any animal models that reflect the clinical trial. In this particular instance, we have a NASH model based on high-fat diet and TCL4 induction that yields efficacy results consistent with the outcome not only of the 3 compounds mentioned in the last slide, but also the 2 additional compounds. Unfortunately, 3 of the 5 compounds did not meet the endpoints in the clinical trial, but nevertheless, the animal results are consistent with the clinical trial. So why animal studies are so important? Or to be more precise, why picking up the right animal model is so important? In a review published almost 10 years ago, it was disclosed, among other observations, that the lack of efficacy contributes proportionally higher to the failure of late stage of clinical trial, phase 2. Of these failed trials, biology plays several major contributing factors. On the top, 40% of the cases are due to target linkage to disease that are not fully established, due to animal models that are not validated. The third on the list, 20%, clinical indications selected do not fit the obvious preclinical evidence. That's 60% in total. So the importance of animal study is quite clear, and it's demonstrated, arrogantly summarized at the bottom of the slide. A case in point is NASH clinical trial outcomes and the animal studies. So how do we judge the validity of an animal model? Of course, we could use standard of care drugs to validate animal models in a posterior manner. But can we do this a priori? In other words, based on what can we make an assessment of the validity of a given model without subjecting it to interrogation by standard of care drugs? Or what if we don't have standard of care of drug to start with? I think we probably could do this by looking at the way an animal model is constructed, the etiology of disease, the related symptoms in the model. If the etiology is the same as the disease, it is expected the symptom and pathology should be the same or at least similar. That is, if we have good understanding of the disease in question. It then follows that the same therapeutic treatment should yield the matching outcome in the animal model. So the validity of such homologous model should be orthologous. If, on the other hand, the disease etiology is not fully understood or could not be fully materialized in animals, but its pathology and symptoms being better understood could be recapitulated to a large extent in an animal model, we could anticipate that the same treatment could yield similar outcomes. The validity of such isomorphous model should be phenotypic. We could extend the hierarchy of another class of animal model of analogous nature. So their validity should be predictive. That is, treatments of different MOA should yield different outcomes. We could debate the terminology afterwards, but if we accept this way of classifying the animal model, we should be able to assess the clinical relevance based on their preconceived validity, of course with cautions. So here's the best example of homologous model is infection. In this particular case, the etiology is the influenza virus, and the pathology, a lung infection, and mortality. So this model is able to differentiate the mechanistic difference of 2 classes of compounds, Alteravir and test article of different MOA, demonstrating the in vivo superiority of the latter. COPD is another example. Its cause is smoking. We could use the same induction method to generate COPD in rats. In this case, the overall histopathology capitulates the difference between healthy and diseased lung, similar to the X-ray of healthy and COPD patient in human. Compared with clinical pathology, this model captures all the relevant histopathology and biomarker, and the standard care of drug, rufamycin, improves all of them. COPD is diagnosed by the functional impairment of post-bronchial dilate expiratory volume of the first 1 second versus the total vital capacity, the ratio being less than 0.7. In rat model, the same ratio, the first 0.1 second, is significantly induced. However, roflumilast, being anti-inflammatory in nature, has no significant efficacy improving the functional impairment in this model, something rather consistent with the clinical observation. On the other hand, the new test article, the new compound, under development, demonstrated efficacy in not only improving the pathology, but also this functional impairment. So what about this NASH model? So well, the etiology of NASH is not fully understood. The animal model captures, different animal models captured histopathology aspects of NASH to various degrees. We compared the two models, high-fat diet plus CCL4 and MCD by transcriptional profiling, and found that they are quite different. The overall correlation between the two models is 0.38. That of lipid transcription, lipid profile, lipid metabolism, more or less the same, and that of inflammation is only 0.05. Mechanistically, they are not the same at all. After two models are treated with obeticholic acid, a principal component analysis of hepatic inflammation and lipid metabolism clearly separates the models from the action of the drug. The first principal component separates the two models, and the second component, the model from the drug treatment. We could infer that although drug exerts its effects in a similar manner in both models, the transcriptional changes in the MCD model has no or little impact on the pathology, whereas the opposite is probably true in the high-fat diet plus CCL4 model. In other words, a transcription profiling alone could not predict the efficacy in animal model unless such changes overlap gene expressions that are associated with the pathology. In fact, the clinical relevance of this model goes beyond histopathology. In the case of resmetirom, it improves the blood biomarkers that are associated with hepatic steatosis, consistent with the clinical observations, even though this model is an isomorphous model. And this clinical relevance extends to the additional compound tested in the clinical trial. In all cases of non-clinical results, their efficacy results in this model are all consistent. At this point, thyroid hormone receptor beta turned out to be the best validated target for NASH, followed by FXR to a less extent. And we looked at the fibrosis observed in this model, believing that fibrosis is actually the most challenging part of this animal model. In the interest of time, I will only summarize what we found. The target of antifibrotic activities of both obeticholic acid and resmetirom are septic fibrosis and the fibrosis in the portal tract. And this is largely consistent with what was observed in the clinical trial of both compounds. So we believe the clinical relevance of this model, although being isomorphous in construction, goes beyond phenotypic validity. Now I'll switch the gear to another class of animal models. The first example is the familiar ARS, a transgenic rat model that expresses the mutant human gene SOD G93A, directly responsible for the disease. If you look at the clinical symptoms of ASL, they're all present in this model, such as motor dysfunction, muscular atrophy and fibrosis, dysphagias, etc. When we introduce an ASO designed to target the mutant mRNA by either ICV or IT injection, significant reduction in the expression of SOD G93A is observed in the different parts of the brain and the different regions of spinal cord. But the level of induction quantitatively correlated with the site of delivery in relation to the site of action. We then use RNA-scope to quantify the effect of ASO on the mRNA from different regions of the brain. And this slide summarizes the result. In all the brain regions, the mRNA levels were significantly downregulated. Having confirmed the predictive pharmacology of ASO on target RNA in the targeted tissues, we proceed to verify the therapeutic effects of this ASO by looking at the survival, neurological score, body weight changes, and the grip strength. It was quite evident that ASO improves all of these in vivo readouts to the levels that are comparable to the wild-type animals, whereas the control ASO had no effects. Now I will pause here for a short summary. According to our classification of animal model, the NASH model is an isomorphous model. Based on our extensive analyses, we could extend this phenotypic validity to a high level of clinical relevance. 3 other models, all homologous, are orthologs in their validity. We now show that in the pure proof of concept studies, they are clinically relevant. So now I will present another transgenic model of Alzheimer's disease, in this case, the 5XFAD mouse model. We will focus on the use of a clinical biomarker in this model, namely the phase amplitude coupling of theta and gamma, or TG-PAC. It is observed in the clinics that PAC is progressively decoupled in mild cognitive impairment and advanced dementia, as shown at the bottom, top of the slide. As shown at the bottom of the slide, a similar PAC is readily observed in the wild-type animal, bottom left. Okay, it is gradually decoupled with time in the model animal, starting as early as 4 months of age. The early onset of PAC decoupling is quite important to this animal model. Although A-beta plaques and glycolysis start quite early in the lifespan of the model animal, the onset of cognitive impairment, on the other hand, is less well defined, the timing of that, from 8 to 10 months or even later. Shown at the bottom of right panel, cognitive impairment was not observed in 6-month-old animal in this particular study, but it was evident at 10 months. However, it is predictively challenging to define the exact timing of the onset of cognitive impairment. On the other hand, EEG is a non-terminal procedure. We could use PAC decoupling to quantitatively monitor the progression of Alzheimer, and as well monitor the efficacy of test compounds to determine when the dosing should start and how long the dosing should last. The application of this clinical biomarker certainly enhances the pharmacological use of this particular model in testing Alzheimer treatment under development. But a 5X FAD model is a familiar Alzheimer's disease with 3 mutations in APP, the substrate of A-beta, and 2 mutations in the key enzyme complex, gamma secretase. And familiar Alzheimer only accounts for 1% of the disease cases. What about the rest of 99% case of sporadic Alzheimer? So the immediate question is, do we have cases of naturally occurring Alzheimer's disease or other neurodegenerative diseases in large animals? So I will switch gear to discussing large animal pharmacology and their use in testing new modality therapeutics. We identified in a pilot study 10 aged and full adult animals from cohorts in our facility. They are grouped based on their performance in a short-term memory test. Aged, low, and high performers and a high performer of adults, as shown on the top right panel. Their CSF levels of A-beta 42 were tested, and the results are shown bottom right. There's clearly a significant difference between aged, low, and high performers. We then did MRI image analysis followed by EEG imaging study. So in the MRI imaging study, we saw overall increase of cerebral ventricle of aged, low performers. After reconstructing hippocampi from MRI imaging, we noted a trend of decrease of hippocampi relative volume in the aged low performers. We then profiled a resting EEG of these 3 groups of animals. In clinics, an increase of low frequency oscillation and delta and theta oscillation, accompanied by decrease in alpha and beta oscillation, is observed in patients with Alzheimer, advanced dementia, Alzheimer and vascular dementia, shown on the left. Alpha beta oscillations being associated with cognitive functions and concentration and attention, respectively. Similar observations were made in the 3 animal groups under investigation, namely a similar increase of the power spectral density of delta and theta oscillation vis-a-vis alpha and delta. Beta, I'm sorry, yeah. And these results, together with other shown in the previous slide, indicate what we have identified in age low performers is probably an Alzheimer-like dementia, a natural occurring, uninduced other than aging. So what about Parkinson's disease? We have seen a natural occurring Parkinson-like disease in animals of advanced ages. However, unlike AD, we could model PD by chemical induction with MPDP, a well-developed model. We have a set of refined behavior tests and EEG tests to quantify the disease progression and use them to monitor efficacy. In the interest of time, I only discuss excuse me, an example and how this is used in testing ASO. So this is a quick summary of the expression of target gene in different parts of the CNS in the PD model using an ASO approach. Okay, I need to point out this is a pilot study, and shown here are the results of after only one dosing. However, the trend of downregulation of expression target gene is evident. In addition to natural occurring PD and AD-like dementia, okay, we have also encountered diabetics, ocular diseases, bone and joint disease, and other diseases in aged animals. Further, we conducted multiple rounds of metabolic inductions in animals older than 10 years. And the two groups of diseases, obesity, hyperlipidemia, fatty liver, NAFLD, NASH, hepatic fibrosis, and atherosclerosis, are likely associated with dysfunction of metabolic lipid metabolism, and diabetics, and diabetic nephropathy, and ocular diseases, heart failures, and most likely associated with dysfunction of glucose metabolism. Here is an example of DIO animal after induction compared with animal of the same age group without induction and those of young animals being less than 10 years, 6 years old. A more complex profile emerged from liver histopathology for NASH in one of the metabolic induction experiment. On the top of are the NS, the NAFLD activity scores, a sum of steatosis, ballooning, and inflammation. And at the bottom, hepatic fibrosis scores. You may note two obvious things. The first, only 4 animals developed a NASH histopathology, indicated by the asterisk. And the second, the same number of animals, developed fibrosis without steatosis. If you stare at the graph long enough, you will also note that about 25% of animals do not present any of the histopathology features, despite the induction. Here are the liver histopathologies of a typical NASH and a non-NASH fibrosis stained with HE and iris red. In the first case, steatosis and fibrosis are quite similar to those observed in human NASH patients. In the second case, the fibrosis is not much different from the septal fibrosis observed on the left. We grouped the animals according to their liver histopathology. It is a bit convoluted. However, it will become immediately clear that histopathology grouping based on steatosis correlates with the blood and the liver level of total cholesterol, and shown on the right. Okay, suggesting the essential role of cholesterol in the pathogenesis of NASH. Okay. They should be used as biomarker for NASH, okay, as you will see in the next few slides in the case study shown next. Okay. So in the first case study, the efficacy of an siRNA was tested in a NASH animal after the induction. Okay, the siRNA is designed to target and expect the gene implicated in NASH. In this study, a single dose of siRNA was used. I'm showing part of the wet data to illustrate the point. We will have more data in the coming days. A liver biopsy was performed before and after the treatment. Compared to the baseline, the siRNA treatment reduced the liver levels of TC and TG, total cholesterol and triglyceride. And likewise, the liver fat contents as determined by MRI imaging were also reduced. The histopathology NAS scores dropped in 3 of the 4 animals treated with siRNA. In another case, a pilot study, okay, the efficacy, another siRNA targeting hypertriglyceridemia was tested. And shown in this slide is the time course of reduction in the blood level of the target protein before and after the induction. And both two siRNA species were tested, and both effectively reduced the target protein. On the left, the concentration; on the right, the percentage of change compared to the baseline. The blood level of triglyceride and ApoA1 were also significantly induced in the study, and clearly demonstrating the in vivo efficacy of both siRNAs. So I think it's time to summarize what has been presented so far. We'll have several disease models in rodents and large animals. They have been and are being used in efficacy studies of new modality therapies. For example, the rat transgenic model of ALS was successfully used to demonstrate the efficacy of ASO therapy. The natural occurring AD-like dementia in large animal is currently tested for AAV and the gene cell therapy. Several large animal models of metabolic disorders have been or are being currently used in testing siRNA therapies, including NASH, hypertension, hypercholesterolemia, and obesity. I will quickly cover another interesting topic that we bumped into in the course of our internal R&D, and that is PCSK9. The mechanism of this established target works through a degradation pathway of LDL receptor on the hepatocyte. In the presence of this protein, LDL through its receptor is transported into the hepatocyte by endocytosis. Once inside, the complex, including receptor, is degraded. However, in the absence of PCSK9, the receptor gets recycled to the membrane and for additional rounds of transport of LDL into the hepatocyte. And this is somewhat akin to Hegelian dialectics. The thesis being the import of LDL to hepatocyte, and the antithesis, negation of this process by PCSK9. The synthesis, negation of the negation of PCSK9 by a monoclonal antibody or siRNA, resulting in more LDL getting inside hepatocyte, and hence the decrease of blood level of LDL. However, when we looked at the blood level of LDL and PCSK9 in the metabolic induction in large animals, it became clear that the increase of blood level of LDL does not correlate with PCSK9 level. In fact, the reverse was observed. After 1 year of metabolic induction, the blood level of PCSK9 was significantly reduced rather than increased, even though the level of LDL increased manifolds. In another round of induction experiment, we followed 3 groups of animals: young animals without induction, 10 years or older, with and without induction. The same results were reproduced. We noted that the blood level of PCSK9 in older animals were much lower than the young animals, and the metabolic induction further reduced PCSK9. In a separate experiment, we used humanized PCSK9 transgenic mice for high-fat diet induction. After 4 weeks of induction, the blood levels of LDL is significantly increased, the right panel. However, there was a greater than 50% decrease in the PCSK9 level. After treatment inclisiran, the blood level of PCSK9 continued to drop as expected. However, the LDL level was not affected by the decrease of PCSK9. In this instance, the Hegelian dialectics broke down, indicating a different mechanism other than PCSK9 was responsible for the increased FDL. We are currently testing incretin in various large animals to verify this observation made in humanized mouse. So, of course, this shouldn't come as a surprise, given that FDA approval of inclisiran clearly defines a particular group of patients with refined existing conditions. So I will not go through the detail. Okay. So what I hope is that during this presentation, we provided ample data to support the use of homologous models or well-characterized isomorphism model in order to improve the translatability of preclinical animal studies. In particular, the use of large animal is highly warranted in testing new modality therapies in the preclinical setting. As always, as George Orwell succulently pointed out a long time ago, all animals are equal, and some are more equal. In animal studies, just as in statistics, all models are wrong, but some are more useful. So we should always keep that in mind. So with that, I should wrap up my presentation. And thank you for your time. And I wish to acknowledge my teams and 3 distinguished colleagues of mine for their support. And thank you. And I will stop here.
Thank you, Dr. Deming Xu, for that excellent presentation. And as a reminder to the attendees, you can continue to ask questions through the Q&A box on your screen. We do have some questions. So the first question is regarding the PCSK9 experiment discussed in your presentation. Which humanized transgenic mouse was used? And have you tried other transgenic mouse models?
Well, thank you very much, Kavya. Thank you very much for the question. This is actually quite interesting. There are 2 models, humanized PCSK9 model, one with the 3' and untranslated region, and the other is without. And the one we tested is actually the one with the 3' UTR. Okay, so whereas the other humanized model without the 3' UTR, we're currently testing it. We're not sure if we can recapitulate the same phenotype see with the other model. Okay. So the implication is that the 3' UTR is probably, if we see any difference between these 2 models, okay, the implication could be that the 3' UTR is probably involved in somehow regulating the level of PCSK9 at the post-transcription level. Okay, so that's something will certainly have implication in the clinical application, a clinical indication of this particular target. Thank you.
The next question is, could you please elaborate on the use of your Alzheimer monkeys in cell gene therapy? Have you identified plaques in these animals?
Thank you very much. Again, this is a good question. Yeah, I think whoever asked the question recognized that we have not shown any evidence of the plaque in this particular animal, I would say more natural occurring animal condition. So that's why I called it this Alzheimer-like dementia. Okay, so what we've shown that is the evidence for dementia. Okay, cognition and the EEG, and these are all consistent with dementia. Okay, so what is being currently being tested is actually the imaging of these animals, trying to see whether we see the plaques. Okay. So the other part is the use of this animal in the gene therapy. Okay, so because these are natural occurring dementia or Alzheimer-like dementia. Okay, so currently these animals are being used to test the efficacy of regenerative medicine. Okay, being whether it's the gene therapy or AAV therapy. Okay, so the idea is if you improve the regenerative mechanism, the regenerative aspect of the CNS, whether that can improve the Alzheimer symptom. Okay, so this is quite different. Our model is quite different than for example, familiar. Okay, right? Because these are natural occurring disease, and it's a slow process. So I think it's a perfect match for looking at neuroregenerative medicine. So I think that's why they're used for this. Okay, I'm not sure how much it's related to improving symptoms, because the symptoms in these animal models, okay, behavior symptoms other than the cognition, okay, is actually rather mild. So, but for regenerative medicine, okay, it is a perfect match. I hope I answered the question.
Thank you. And the next question is, in the COPD rat model, how long does the smoking induction last? I assume it takes quite a bit of time. So the follow-up question is, do you have a shorter version of COPD? Is there any difference between the two models?
That's very good. Obviously, the model presented in my talk, okay, it's a 4 months induction and could go as long as 6 months. Okay. So obviously this is time consuming, and I would say an expensive model. Okay, and we do have a shorter version of LPS plus smoking, and that's about as short as a couple of weeks. Okay, but the disadvantage of that model is that you don't see much pathological change other than inflammation. So that model is based on LPS plus smoking. Okay, so it mimics. It takes into consideration the smoking. However, the inflammation part, okay, of the perhaps related to COPD is captured in this model, but only the inflammation. Okay? But if you want to look for pathological change, if you're looking for respiratory functional change, okay, that short motion does not capture these changes. Okay, so yeah, so you have the advantage of the long model captures everything. The short model, being short. Okay, if you're only interested in anti-inflammatory, that's your choice. Okay, thank you.
The next question is, do you usually use positive controls for AD and PD models?
That's a very good question. So really, it depends on the animal model, okay, right? If it's in the it's even in the case of 5-XFAD, okay, really it's hard to quantify any particular model, a particular drug as a reference, okay, because it's just so hard, okay, right? And also the timing of dosing, how long it lasts. Okay, so these are the variables you have to take into consideration. And when you talk about a reference, okay, so usually it's the selection of drug or compound is fixed. Okay, right? The dosing, starting dosing time, and the duration of the dosing should be also fixed. Okay, so we're seeing the 5-FXAD. Okay, so these are not. All these parameters are not fixed. So it's very hard. We have success examples that could use various compounds of various mechanisms. Okay. And yet, if you without the EEG, the PAC, okay, it's very hard to reproduce results in another batch of animals. So I wouldn't call it a standard as a reference. Okay, I would just call it. I wouldn't call it a positive control rather than a reference. Okay, so I think with the application of EEG, okay, perhaps we could standardize the reference. Okay. I hope I answered your question. Okay, thank you.
Which is the best preclinical model for AD?
I would say the non-human primates would be the best fit if we can show plaque in these animals. Okay, so there are attempts to reconstruct AD in monkeys, for example, using plaques purified from human. Okay, right? But these experiments are not reproducible. The plaques from different patients may or may not reproduce the phenotype. Okay. Whereas natural occurring AD or AD-like dementia, shall we call it? Okay, I think they're more relevant, and I think that if you of course, if you look at the if you want to look for shorter, cheaper way, inexpensive way, rodent could be the choice. And in the case of rodent animal models, okay, we have many choices based on the pathology. For example, if the target, your interest is the plaque, okay, so the A beta model, the 5XFAD, okay, could be a choice. If your target is the tau protein, okay, so we also have mutations in tau, okay, that also recapitulates part of the Alzheimer condition, okay. So really, it depends on your therapeutic strategy, and based on that, we could select the matching model. Okay. But I would say the best choice is probably still non-human primates if we can show plaque in these animals. Thank you.
The next question is more general. You discussed the first two classes of animal models, homologous and isomorphous. What about the last class of the so-called analogous models? We probably have more such animal models for diseases with not enough understanding. How do we approach such models, and how do we study their clinical relevance?
Thank you very much for this question. Okay, this is indeed true. Okay, we have more analogous model than the homologous and isomorphous model. And I think the best way to validate, you have to validate analogous model. Okay, right? So in the case of such models, okay, I think you have to have some kind of standard of care for validation. Okay. However, one of the characteristics associated with the analogous model, being the validity being predictive, is that we have a different mechanism, different mechanism of action. Okay? So the readouts should be different. Meaning, if you can use that model to differentiate compounds of different MOA, and then I think it still has a validity. Okay, so it can distinguish two classes of compound, right? So that, in a sense, that it has limited validity. Okay. However, in terms of clinical relevance, that's another concept. Okay? Validity and clinical relevance. Okay. The clinical relevance, I think that you need more extensive study. I think you probably need more time. Okay. And if you're looking at IND filing, okay, perhaps you don't have to go too deep. As long as you show efficacy, some differentiating efficacy is enough. Okay. However, if you are interested in the ultimate clinical outcome, okay, perhaps you should spend more time in validating such a model. Okay, perhaps you have to follow the clinical outcome of the compounds tested in this model, see how they perform in the clinical trial. Okay, I think that's the best way to test or whether validate or otherwise. Okay, the analogous model. So unfortunately, we do have a lot of such analogous model. Okay, so I have to say, whether they're fully validated clinically, okay, that is an open question. Okay, so we, as part of the pharmacology, pharmacology studies. Okay, so pharmacologists. Okay, so I think in this community, so we should put more effort into validating such models. Thank you.
All right, that's all the time we have. Thank you again, Dr. Xu, for your fascinating presentation, and thank you participants for being a great audience. Be sure to check CNEN or CNEN Online for information on the next edition of CNEN webinars. Thank you On24 for technology and production services. And thank you to WuXi AppTec for the sponsorship that made this interactive webcast possible. For CNEN webinars, I'm Kelly McSweeney. Goodbye.
Thank you, and bye-bye.